Welcome. I'm Dr. Sue Borson, and I'm here with my friend and colleague, Dr. Joshua Chodosh. We're so excited to bring you today's webinar from our CDC-funded BOLD Public Health Center of Excellence on Early Detection of Dementia. As experienced clinicians, Josh and I have had the privilege to build deep partnerships with many people who have implemented detection and diagnosis programs across the country. We're really excited to have all of you join us today. I want to share a few reminders about this webinar. It will be recorded and shared with all of you via email and posted on our website. We'll have a Q&A session at the end of the webinar. If you have any questions during the session, we kindly ask that you make a brief note of that. If your question is not addressed during the conversation, please use the Q&A box located at the bottom of your Zoom window for the Q&A session at the end of the event. It's important for us to know about how you experience our webinars. At the end of this one, you'll be invited to take a couple of minutes to complete a short survey so we can continue to tailor them to things that you're interested in and want to know about. At the end, we'll share the survey link in the chat and the QR code on the screen. We're really excited that you've been able to join us today to hear from our colleagues. I'm handing off now to Josh to introduce our panelists.
Great, thank you, Sue. And it's really an immense pleasure for me to introduce our two really terrific panelists. Dr. Joy Ballsbury is an associate professor of neurology at Washington University School of Medicine and the inaugural core leader for the Health Disparities and Equity Core in the Knight Alzheimer's Disease Research Center, the associate lead for community engagement for precision health for the Institute of Clinical and Translational Science. Welcome, Joy. Dr. Robert Turner is an associate professor in the Department of Clinical Research and Leadership. He has a secondary appointment in the Department of Neurology at the George Washington University School of Medicine and Health Services. And welcome, Robert. You can learn more about our panelists by clicking the links I think that have just been shared in the Zoom chat. So maybe just to start, I'll just start off with a very general question to both of you, and really want to ask you, what motivated you to start your work in dementia detection, and as a side to that, what did you want to accomplish?
Robert, did you want to start?
No, I would have please. I'd love for you to go first, please.
Okay. So it's a funny story, but not. So I started off as a HIV and AIDS researcher. And so I used to tell people that I used to study sex, drugs, and hip hop. So we just celebrated 50 years of hip hop. I'll be 50 on the 27th of this month. I don't lie about my age. And, as I was going throughout my studies as an epidemiologist, and then eventually doing my Ph.D. In health education and M.P.E, I would later do a postdoc at University of Florida, and I became a Pepper Scholar at UF. And so that was kind of like my first tray into the Alzheimer's disease, related disease and dementia space. And then one of my dad's best friend was diagnosed with Alzheimer's disease. And we, culturally within the African-American community, I considered him my uncle. And so as time would go on, I would help and I would hear stories. But at this point, I wasn't doing research in that space. So I'm known as a theorist, community outreach, community recruitment, research enrollment. That's how people see me. And then eventually I would take a job in Minnesota at Mayo Clinic, and I was on faculty there for 8.5 years. And while I was training there, I was asked if I wanted to be a faculty trainee in aging. And at this point, I'm publishing on theories and community engagement and patient-centered outcomes research, but nothing disease specific. And my uncle would die. And I was invited by John Morris and team to talk at the Knight Alzheimer's Disease Center in 2018 to talk about research enrollment. And then I told my uncle's story a few times, and my mom had some cognitive health concerns. And so this ends up being very personal to me. It's not just about thinking about not only the disease, but prevention of the disease, and how Alzheimer's disease is linked to a variety of other conditions, from diseases of the endocrine system, from diseases of cardiovascular health, but then also thinking about healthcare deserts. When Dr. Morris, or John Morris, who was the previous PI of the Night Alzheimer's Disease Center, we're now led by Dave Holtzman, with John leading the clinical core. I'm from St. Louis, so I know the areas of needs here. So when the opportunity came for me to come back home, I had no idea my mom was as sick as she was. And she would pass. I thought about the fact that areas and health clinics and the areas for the Black community were closing and had closed, that maybe I could help in those spaces. And so for me, this has been very personal. And I'm hoping that we are making change.
Thank you. Robert?
Yeah. So Malcolm X once famously said about Black Americans, he said, we didn't land on Plymouth Rock. Plymouth Rock landed on us. And in a great deal of ways, I did not pursue a career in gerontology or Alzheimer's research. It pursued me. I never knew that that I was going to land in this place. And believe it or not, Dr. Chodash, you may remember this, but you have a very strong, deep hand in guiding me through this. Because we talked very early, as you know, when I was a Pride scholar, and I first started out looking at wanting to know the connections between sleep and really neurodegenerative diseases like CTE. And we sat down, and at that time, it was early, and my dad has Alzheimer's. I'm his primary caregiver. And early in that time, we sat down over beers one day, and I was telling you about my dad, and you said, I bet you I can tell you that your dad has a really strong support system network around him, given his age as a Black male and all that he's gone through. And, long-term, very stable home, married to the same woman 55 years before my mom passed, lived in the same home, had a great job. All of these had full insurance. All of these different things helped me realize that you were just checking off the box in terms of the risk factors that would lead to my dad dying much earlier. He's 85 years old, and he hasn't passed yet. But what has preserved his health, and what has allowed him to live this long life, even with a neurodegenerative disorder that he has. And of course, so it's very personal to me, just as Dr. Ballsbury just mentioned, and I've had several aunts that have passed complicated, with Alzheimer's. So ultimately, as I started going through my journey, and I started off as a sociologist doing urban ethnography, but the questions that I had about and the links all drove me towards, getting the training that I need to be able to answer certain kinds of questions, and particularly around health disparities. And as we will talk about, my work really does involve, for the most part, but not exclusively, but for the most part, Black men, older adult Black men. And I look at how they age across the life course, brain health and aging, and what are the issues that happen early in their lives that may increase their risk factors for these neurodegenerative disorders, or in some instance, what preserves them and protects them. And so trying to understand those health profiles, so that way we can, and my work can help as far as biomedical, psychosocial approaches in translational biomedical health. We can all work together to try to solve some of these really deep and important problems.
So both of you have mentioned your personal experience with dementia and Alzheimer's disease as drivers of your professional commitments. I think we have a couple of streams here that I'd like to pick up on. One has to do with the theme of involving communities of color, most particularly in research activities, because we recognize that disproportionately affected populations with high rates of dementing diseases or effects from many causes we don't know as much as we need to know. about disproportionately affected populations, such as African Americans and others. So, but the personal link that you have, that both of you being African American and reaching into African American communities to use your personal experience to leverage research, is something that I know our audience would be really, really interested in learning more about. Just one final comment about that, and I think we're all sensitive to the fact that trust is a fundamental issue in both clinical care and in research participation. And both of you have been successful in building trust. Could you comment on this and what the core elements are of trust building when you're reaching into communities that historically are underrepresented, both in our clinical practices as specialists and in our research?
Joyce, would you
So,
want to jump on that first?
yeah, so, okay, so my first experience in public health was as a baby. So, so my dad was a public health guy. He had been a health commissioner in East St. Louis, Illinois, which is 15 minutes from St. Louis. And he was health commissioner during a time when East St. Louis was considered the murder capital in the US. And I would go to health fairs with him, or to churches, or to other things. And honestly, I got to do some really cool things, like, you know, during the Don't Drive Drunk era with Stevie Wonder. I got to meet Stevie Wonder when I was 13 for a health campaign. And so for me, this is innate. Like, this is like, we would plan our family vacations around American Public Health Association meeting, you know, and so it ended up being a part of the natural lexicon of how we were raised. My mom was an educator, a high school teacher. And so I remember stories from my childhood about the health system where I work. And I remember one of my grandmothers saying that she was not allowed to have her babies in the hospital that's connected to our system. Well, those babies that were born in that time period are between the ages of 75 to like and older, right? Those are the patients that we're now seeing in the memory diagnostic clinics and geriatrics. Their children are my age, or their grandchildren are younger than me, right? So when you think about that, all of that goes back to trust, right? And then the main hospital and the area for the poor and underinsured, which was staffed by WashU physicians, the city closed. Not at any fault of WashU, not any fault of the BJC system. It closed for a variety of reasons, right? A lot of hospitals closed in the late 90s, early 2000s, in Black communities, Black and brown communities. And so the thing that I'm noticing, having been coming back to St. Louis, or in terms of trust, are a variety of factors. One is thinking about fatalism. If I go to the doctor, I'm afraid I have cognitive concerns, and I go to the doctor and there's a diagnosis. I'm not going to go to the doctor because I don't want the diagnosis. So that's fatalism, right?
Right.
The other piece goes back to ethics and the principle of justice.
Yeah.
If we know that someone is eligible to be in a project, this is researcher bias, study coordinator bias, recruitment team bias, PI bias, physician medical team bias, but yet we don't give them the opportunity to participate because we have the assumption that they won't complete or be able to retain, then we've self-selected people out without asking them whether or not they want to join. So
Right.
that goes back to that area. Another piece is thinking about what we call, we talk about functional literacy, the ability to read and write. I live every day with dyslexia and ADHD. I don't lie about it. I did a TED Talk on living with dyslexia as a scientist. People know it. But there's also health literacy. Can you understand the health information that is given to you? But then there's also biomedical or health research literacy. Sometimes we'll have so many steps in a consent document that study participants will leave. And so we don't think creatively with the ethics groups and the community partners on how to design study materials and consenting documents in a way that are culturally tailored, that speak to cultural intelligence, that speaks to the breadth of how communities want to be seen. And then the other piece is thinking about measurement. And every single one of us on this call has probably done it, no fault of ours, but we will sometimes say, well, such and such is more, the disease is more prevalent in this community. So we know African Americans are twice as likely to be diagnosed with African American Alzheimer's disease or dementia. Hispanic and Latin communities 1.5 times more likely. We know that. That's fact, right? I mean, epidemiologists count and sort really well. But race and ethnicity is not causal factors for disease.
Right.
And then often when we interpret results, we make it appear that race and ethnicity are causal factors to disease linkages, instead of looking at the underlying issues related to social and structural determinants of health, like discrimination, racism, like the inability to have access to care because there's no place to receive care, or shortages in specialty clinics that, or physicians trained or medical staff trained in looking at dementia. So how do we address that in a way like the workforce issues at the clinical level? So, like many of our colleagues who are on this call, you all are clinical practice. I'm not. But what can Robert and I both do on the other side of medical research to help you tell the story about what you need on the clinical side, so that the health system says, okay, we now have the data, because data don't lie, but how we interpret data can influence what happens within a system and how systemic change is fostered. So that's my dyslexia. Sometimes I can't get the words out like I want to. But I think that there's a variety of issues: fatalism, justice, research literacy, and then even thinking about measurement and systemic change in terms of really being able to build trust. But that also means taking ownership of what our systems that we worked in have done not to be supportive of future care.
This is fantastic. If I
really
may, I want to add one question to the pot, not necessarily for you to answer instantly, but sometime during our conversation. One of the gaps in our understanding of outreach has to do with what people in different communities want from clinicians, what they want regarding, say, diagnosis, how much of a diagnosis, what kind of support, what are the things that we as clinicians and researchers need to be attentive to in terms of forming partnerships. A lot of our conversation is about what we want you to do, but how about what you want us to do when we're speaking to members of our communities?
And I
With that,
know
I'll
from
sort of
that.
stop and Josh, do you want to add
Well,
to
that's a
that?
question. That's a question for right now, because it certainly dovetails into the trust issue. And I know that, Robert, you've told me some really fabulous stories about your conversations with Black men around healthcare and trust. And so some of that must be related to not just what people don't want from the medical community, but what they do want. And I wondered if you could share some of that.
Sure, sure. So as I mentioned before, I'm trained as a sociologist, right? And so I really focus on my initial training is always focused on understanding people's lived experiences, right? How do they, no matter what this is, right? Whatever it is, if we're talking about Alzheimer's and dementia, or we're talking about any other health or any other issues, but the numbers will tell us a great deal of what's going on, right? But I think contextually, their lived experiences can tell us how they live through it, or any of these other things. And so I'm going to start off by really, Josh and I, Dr. Chodas and I are from right down the road from each other, and he's from Hillside, New Jersey, and I'm from Newark, New Jersey. And and, we're roughly the same age, or within a while. And so growing up at the time that we grew up, Newark happened to be, it was under deindustrialization. Newark happened to wind up being a very segregated city, and it was around the time of Newark having I think the very first riots, back in the 67s. And so I remember I asked my mom, and growing up through all of that, and then we moved out to Central Jersey, and I asked my mom once, not long ago before she passed, I said, Mom, I said, all of the research talks about Black people not trusting the healthcare system and medical system. And I said, but why is it in our family that we are so engaged in the doctors? Why do so many of our families go into the doctors? And so part of that was my mom gave me an answer, and it helped me really contextualize this. But my grandparents, and then when I was young, when it was very segregated like that, the doctors lived in the communities. Right. So you may remember, some of y'all may know Dr. Robert Fullerlove, who's at university.
Yeah.
He's at Columbia University. Well, he and I were talking a long time, and come to find out that Dr. Fullerlove's father, he was the community doctor, he was my grandfather's doctor. Right. So, so it was a different level of engagement, particularly at when you go to church or you go to the store and you see these people all of the time, right? And so it wasn't even a matter of trust. And in some instances, that's all you had. That's the only access you had to go through. That doctor was everything. He was, everything in the community. And so how that generation in my family, my grandfather and my grandparents, right, they grew up with a much different relationship than we have today with the doctors, right? But then also looking back, every one of the men from my grandfather, my father's generation, my uncles, they all went to the military. They were all in the military, so they all had all of their engagement with the doctors through that, right? So that's how we learned to go. And I remember my dad was also in the union. And so one of my earliest recollections was when I had to have braces, right? And I didn't want to do it, but connecting that back to the fact that my dad was electrical union, and they had the kind of insurance that allowed me to go there. So in our family dynamics, in my extended family, going to the doctor was very normalized, right? But then I think now, like in the way that my other family members that live in Newark and those kinds of things. And whenever I think about doing research, or I think about engagement into the healthcare system, I always think about what is their experience, what is the environment that they live in, how have they learned to engage in with the doctors. And I've come to really see that from their perspectives, and many of my younger family members, they don't, trust is not a word in doctors that they use. And I don't necessarily know if from research, if we ever do gain trust, just because someone says that they're willing to get into a study, does that mean that we've actually gained trust? I think what it means is that we've gained their agreement today to get into a study. Right. And anytime we try to conflate that, I think we get ourselves in a lot of trouble. And so I think that I also, from a sociology perspective, I come from the perspective when people say, when you present something to someone, they're going to say, what's in it for me? At least when I deal with Black men, right? They love the idea that, yeah, okay, my mom may have had it, or somebody in my family may have had it, and so therefore I'm connected to the disease. But at the same time, they're still weighing that against, do I know who you are? What are you going to do with my data, right? Because it's the person that's in front of me. I've had people call me and say, hey, listen, I know that you have assistants that are out in the field, but I want to talk to Dr. Turner. I want to look at you. I want to see you. What really has come back to me is, are you a brother who's from our community? Or are you from someplace else just acting like this, and then you're going to be gone? But I need to know that you and I share similar experiences, right? Because I'm putting it on you that if you say you're going to do this, I expect it to be done, right? So I just want to, I could unpack that a lot of different ways, but I will just say that I don't want us to get caught up in this fallacy that thinking because, oh, they have invited us to come speak, or I'm a speaker at a dinner or a lunch or something like that, and they've decided that they're going to get into our study, that we have gained trust. I think that we owe a lot to people who have decided to, for whatever reason, take a chance into our research, walk into our front doors, our clinics, and other things. But it is on us to prove every day that we are worthy of the time that people give us for the research that we do.
To piggyback on that, I think that I pulled up my most cited paper as a PI is a paper that I did with my dad before he passed. And he served as a senior author on that paper. So that's kind of cool, right? And there was a quote in there that said, Black men don't tend to go to the doctor. They think they're all right. They'll say that it's a headache, and it's not a headache, I'll be all right tomorrow. And that can be translated in so many communities, right?
Right.
Especially in St. Louis, right? Like I think about the fact that, like Robert, my family went to the doctor. My dad's brothers were in the military. He was one of the only ones that did not serve. He did ROTC in college, and then he and my mom were married. They were married 53, almost 54 years when he passed. And then again, very similar situation in the neighborhood where they both grew up. Next door was the preacher. The other door was the guy that worked at the post office. The mortician lived down the street, and the dentist and the doctor were right there, and so was the lawyer. So when you would go to the grocery store in the Ville in St. Louis, which was where they both kind of grew up until our families moved outside of that area. This is the area where Tina Turner grew up, where Arthur Ashe grew up. And so you think about this Black community that once people started spreading out for larger homes or for other opportunities, once redlining was starting to be addressed, and we still have issues of redlining laws in St. Louis,
Yeah.
the neighborhoods changed, right? And then with that change, and then I grew up with, because my parents were both college educated, where my friends' dads and moms were college professors. Their parents were judges and things like that. And I recognize that that's a place of privilege. But my friends that I went to high school with, some of them still grew up in the Ville, and their families did not have those opportunities, the same opportunities that I had. So in knowing that, it means then how do we, so once Homer G. Phillips Hospital, which I think some of you all may be aware of, it was one of the first hospitals, teaching hospitals that trained a lot of African-American nurses, physicians, radiology technicians, phlebotomists, you name it, was in that neighborhood. Well, eventually it closed. And then once that went away, the neighborhood shifted. And those physicians started going other places. Those nurses started going other places. So the system and the city changed, and then disparities started slowly rising in communities where there were resources. And so now coming back home, like I was gone for almost 20 years, I was gone for 19 years, and then I moved back. And I would come back and visit, but coming back and visit and just popping over a friend's house is different than living in the community. And like Robert said, like a couple weeks ago, I go to the church where I grew up, and they call me Joy. I'm James and Joyce's daughter. I'm named after my mother. I'm Dorothy's granddaughter. When I go to the church where my dad grew up, they're like, oh yeah, we remember when you used to play over there behind the pulpit. And so there's all of these stories. So there is some trust because I grew up in these communities. So that means that I have a bigger responsibility because I don't want to harm people that I'm connected to. Does that make sense? And I also don't want to do helicopter research. We
Right.
get the money from NIH, we get the money from CDC, we get the money from some foundation. We come in, we ask a whole bunch of questions. We get some biomarker data, be it MRI, saliva, microbiome stuff, blood. We put a Band-Aid on it, we give a gift card, and we leave. And then we get promoted, and the community is still living in the same place that they were living in before. So what can we do differently? So one of the things that I do in my research programs is we do community needs assessments. I'm an epidemiologist, Robert's a sociologist. So there's these bigger connections of wanting to ascertain. Josh, you asked about, well, what do they want physicians to know, right? A lot of it goes back to wanting to be seen as a person, and wanting to be heard. So I just did a training for resident physicians and postdoc fellows and medical students. And I asked the question, if a patient comes to you and say, you know, my sugar has been a little bit off, do you know what that means? Out of the 50 people in the room, only 2 people knew what that meant. But yet the patient leaves out and nobody's tested to see whether or not they have diabetes. So it's also the language that we use, and we want to make sure that we are not hurting people and learning the lexicons of the communities in which they come from, but open to hearing them in a way that medical diagnosis can happen in a timely manner. And then also being willing to follow up and not getting upset. Like, for instance, Robert and I both have been caregivers. When my mom was dying before she passed, this was like the 2 hospitalizations before she died. She was in the ICU, and the attending physician that was on duty decided that they were going to yell at me in the hallway for asking to speak to an attending physician, and asked me what gave me the right to ask to speak to an attending. And
That's kind of shocking.
no, don't be shocked. This happens all the time. And then a
Yeah.
lot of times, PhD scientists, we're not called doctor when we go to the clinical area. I've done 2 postdocs. I have just as much training as anyone else. I might not be on the clinical side. And sometimes it doesn't matter. But if I ask you to use that, then honor what I'm asking, because I honor you, right? And so I had to, and my mother, who never wore her hearing aids, for some reason, this particular day, she had her hearing aids on, so she could hear the whole conversation. So in the background, she's laying in the hospital bed, like, doing like this, pumping her arm every time I say something. And then she's coaching me through this dialogue. And this physician, a woman, cannot hear me, cannot see what my mom is doing. And so afterward, my mom goes, oh my God, I had no idea how you've had to fight for me to get the care that I need. She's like, I didn't know. She said, I thought you were just being a jerk. I was like, I'm not being a jerk. I said, but I am trying to make sure that I'm getting the answers to the questions that I'm seeing in your MyChart. If they say they're going to do this test and then it's not done and the result isn't there, then I'm going to ask, well, why wasn't it done? You know, but don't, you know, so I think that there's that disconnect. There was a joke that a lot of my colleagues used to say, and I've been in biomedical research since the 90s, so a long time. And we would say that there's sometimes an ego that happens in different areas, PhD egos, physician egos, whatever. Sometimes our egos get in the way of us providing the care or the research opportunities that we need to be providing, which ends up setting up another bias.
Right.
And how do we train the next generation of physicians to say, okay, you might think it's this, and then you've told Mrs. Jones to go, okay, I'm going to give you this prescription for Ozempic, but I also want you to go out and take a walk every day. Well, she doesn't live in a community with curb cuts because she lives on a farm. And she may not want to get out there and walk amongst the horses. Or she might live in a neighborhood where there's no street lights for her to get out and walk. And so it's thinking about what the patient's environment outside of the system. And it's the same thing when we do research. So my lab, most of the data that we collect, we don't collect most of the data here. Like I'm on campus today, but we're usually out in the community. We have data collections on campus, but then we also have data collections at community centers, at churches, and we bring all of our stuff out there. Because guess what? It's easier to go to where people are. Why do they have to come into the phlebotomy or go to Quest Diagnostic to get their blood draw? We got phlebotomists and nurses. Why can't the phlebotomist or nurse go to the church or go to the barbershop or go to, why do we make it impossible for us to even provide the clinical care that we need to be providing? And then it goes back to research as a secondary thing. So the moral of that story with the physician that decided they were going to call me out, and the response was, I think you need to be softer. And I said to her, I said, what do you do? I asked her, I said, what do you do? And she was like, well, I'm one of the first women surgeons here at WashU. And I said, are you soft? And the response was, no. I said, do you have daughters? And she said, yes. I said, are they soft? And she said, no. I said, I am an epidemiologist that mainly works with white guys. Why do you think, and was trained by mainly white guys? Do you think that I'm going to be soft? And she said, no. I said, so don't ever ask me to be soft again. I said, because in the end, I'm typically the only Black woman, the only Black person, sometimes the only straight person, and I am direct. And so I think that we have to think about how can we give voice to community, hear community, understand the cultural aspects of it. So like another example, in the psych space, we have patients, some community partners, and even in the dementia space, where they don't want their older adults to know the diagnosis, and it's a cultural thing. So how do you navigate that with research? We have to ask those community partners, how do they want us to navigate it? What are the cultural implications of what we're trying to do? And then partner with the institutional review board to make sure that they understand what the community feels is harmful or not harmful, which is different. And that's not easy either, but we can do it.
So I want to mention a finding from a study that I've been involved in recently with a mainly African American group of dementia caregivers. And not to jump the gun, because this is a paper that is in review right now, but it was so striking to me to learn that when asked about experiences of discrimination in healthcare, nearly half of our caregivers said they had had at least one experience of discrimination in healthcare. It strikes me, you've raised the question, Joy, about we've got to do something different to train our next generation of researchers and clinicians. Certainly we need to be doing that. We need to be training each other as we go too, not just the young ones, but everybody, as you were doing with the surgeon that you encountered. Should we be studying in depth more about these experiences of discrimination so
Let
that
me
they
jump.
unpacked? Yeah, go ahead.
Let me jump in here. I just real quickly, because I know time is running. I knew this was going to wind up happening. We want to open it up for questions as well. But I want to just kind of riff off of something a little bit that Joy has said. That in my experience, and I was not, I wasn't prepared for it. But in the community, in different communities, right? My role as a researcher, or as a doctor, has been viewed in certain ways in reverence, actually, with a lot of respect, right? And it is tied very much to what Joyce was talking about, and I'll explain to you how. So I do a lot of work with former football player, right? Because I'm a former professional football player as well, and to a T, the older black athletes will always refer to me as Dr. Turner. And I will say to them, no, I'm Robert. And they were like, no, no, no. You're one of us. You earned it. And we want to show you the respect that you deserve.
Mm-hmm.
Right. And that's because what they're saying in a lot of respects is that you embody more than just an athlete. And we need our other young black men to see that there is more than just sport. So when you show up, plus you have the knowledge that we need. So we want to respect the training and the knowledge that you have and that you can share with us, right? And when I go into the black communities as well, it's the same exact situation. Older black men and women, but they always are saying to me, "We're going to call you Doc. You're a doctor," right? Because you represent to us and you have something that we need. And so I think in part of the equation in the research, in particular, or being out in the community, is in terms of wanting to give the best care, clinicians and everything else, we have to understand, and I'm sure people are aware of this, but I feel an obligation, and I would call for all of us to feel an obligation to try to reach out and see as many young people who are from these different backgrounds, right? To train them, right? Give them an opportunity. As a football player, let me tell you something. When I went to college, I only went to college to be a football player. And I was unsubscribed to that C's, get the degrees. There was no way that I was ever going to get a Ph.D. But somehow or another, through the grace of God, other people believing into me, and then me learning how to believe in myself, am I in a position to talk to you all today about the things that we are. And there's a lot of very talented young folks that don't look like me that are out there, and they just need someone to reach out to them, give them a chance, open up and work with them, because they're going to be some of the strongest assets that we have to reach out into these communities, but we have to cultivate them.
Yeah.
Robert, what I hear both of you saying to some level is it's really about respect. That respect has a very close relationship to trust.
Mm-hmm.
And I think when people want to respect you and they insist on some expression of respectfulness, what I'm hearing is they want to be respected. They want to be, that's an act of respecting themselves as well. Right. And I want to there's been something that's been a little bit of an epiphany for me here listening to both of you. And I wanted to just share that briefly. And that epiphany is this tremendous parallel between what you do as researchers and what some of us do or try to do as clinicians. And it's about one word. It's about presence. And Joy, I think you articulated, and I've heard you speak before, and I've been to the Knight Institute and heard all the wonderful things about all the extraordinary stuff that's happening in the community. But a lot of that is really about presence and respectful presence. And when I link that back to the healthcare community, when I link it back to dementia detection, where is the problem? Somebody might come in and might get the best care possible, might even get an incredible level of feeling respected and receive information, receive some substantive information about their cognitive state and what that might mean. And then what happens next? It's gone. So, the guy that was, or the woman who was down the street from you, who was taking care of people, was very accessible, and you could get to them and always have that. But when you leave the healthcare system, getting back in the door seems to be incredibly difficult. And so it's a different sort of helicoptering.
It is.
Right? But it's very parallel. And I think this is what I think repeatedly violates trust, which is you had that relationship, you had that moment, you felt like you were heard, you got some reasonable information, but then you had more questions or you needed something else. And, God help you trying even to get somebody on the phone that you want to reach to have a conversation with.
Right. And I apologize. My office phone was ringing in the background.
We didn't hear it.
That's actually my lab number. And I kept thinking my lab shares a wall to my office, and I was like, I think some
Yeah.
of the study coordinators are in there. And so because I'm good for answering, because that's the lab, not my actual backline, because we need to be accessible too, right? So I think that there is this thing, like when I go to the community, and the funny part is a lot of times, sometimes people will call me Dr. Barry, and I'm like, who are they talking about? Because I go by Boss Barry for work, and my husband is Barry. So, and I had my PhD before I got married. And so I'm like, who? I was like, oh, they mean me. And then I feel really bad if I'm correcting someone that's my parents' age that are in their 80s, right? Like, no, I'm Dr. Ballsberry or Dr. Joy. My husband is Barry, and he gets really upset when people say, "How you doing, Mr. Ballsberry?" If you ever want to make him mad, call me. But that, and he laughs now because we've been together a long time.
He
But
learned.
he's learning. He's coachable, and so I think that we do have a great responsibility. So a couple of weeks ago, we did a project at my church, and my pastor calls me Joy, right? And we have a certain rapport because he is my pastor, right? And so I asked him, I said, hey, can I come up to the pulpit, say a couple of things about Alzheimer's disease, and then about what we're doing for recruitment for one of my studies. He was like, yeah. And he was like, well, Joy, this, that, and the other. And so what I didn't know was that his wife was texting him, and other church members were texting him and said, in this capacity, she is not Joy. She is Dr. Ballsberry, and you need to address her as such. And so afterwards, he was like, and he changed how he spoke in the pulpit. And afterwards, he said, I really apologize. He said, I know better because I have daughters, and I know what that means. I know how hard you worked. I know that you are back here in this community, and we want to support you because you were trying to change things in our community. We have a clinic at my church and all this other stuff. And so it goes back to respect of person, which is a principle of ethics.
Right.
It goes back to do no harm, which our physician colleagues have had to take the Hippocratic Oath. It goes back to thinking about times when distrust has happened. It goes back to, so you mentioned discrimination. I'm about to analyze some data where we've used the everyday discrimination scale from Dr. David Williams and some of my research, and looking at that scale in context to some of the data that we're for my R24 grant. And I was just talking to him a few weeks ago about, are we using the scale right? And I'm wondering if we are, right? Because it's a lot of publications on it, but I don't know if people are connected with him on how to interpret the results that we're finding and the impact of those results. And so, and as someone who has lived with a misdiagnosis, or know other people that have lived with delayed diagnosis, based on our experiences of racism or discrimination or genderism or other phobias and isms, we have to acknowledge that, because guess what? We are human and we're not perfect, but we are human, and while we aren't perfect, we are teachable. And so, at least I hope we're teachable.
Well, that's a good segue to a question in the Q&A, which
Yeah.
is, what would you recommend? This is from Susan Winthrop. What would you recommend for people to say and do when they go in to see their clinicians to increase trust?
Great. So I'm going to jump on that real quick, and something that Dr. Jordash had talked about, respect, and I suspect it's the same thing with other populations. But I can tell you this much: with Black men, you do not do research with them without understanding how important respect is. Right.
That
And
part.
I'm talking about from young kids, because you will hear young kids, you ask them like, okay, why'd you do that? What's the beef about? Why were you so aggressive? Why'd you even shoot and kill somebody? Sometimes they say, because he disrespected me. right?
Mm-hmm.
Respect is so vitally important, right? And then with older gentlemen is, they will demand the respect that they deserve for having, become older. And I grew up in a family that, you show respect to the women in the family as well. So respect is all over the place, at
That
least
part.
in the Black community. So I would just kind of say that. And, just to kind of unpack this other question, that's a great question. What do you say to the clinicians? And I know clinicians are way overburdened. If you get 15 minutes with your patient, that's a lot. But I think the thing that you want to be able to ascertain in your own way of communicating is if you can, in one interaction or the very beginning or at any point in time, ask a clinician, what do you do to ensure that you take a moment to get to know your patient, what's important to your patients? How do you know who I am? What is your strategy for getting to know me and what's important to me?
I, I,
Great.
I love that. Can I piggyback on that real quick?
Mhm.
So there's some research on an area from UCSF on structural vulnerability, right? And then Ganesh Babala and I published a paper on dementia health disparities, where we actually took that model and came up with new questions to ask on the clinical side around thinking about structural vulnerability as it relates to a dementia and cognitive health concern. So I'm wondering if we've got to train the next generation of physicians, and it even goes back to a question that Megan was asking, of thinking about asking more questions about not only the reason of the primary reason for visit, but also about showing great interest in how the person lives their lives, what is important to them without judgment. And that's hard, right? But then interest. I think that that's a big part of it as well. Does that make sense? So like when you go to your initial visit, and then also the feeling of, and this is outside the hands of the physician, because this goes back to the hospital administrators that said, you only get 10 minutes to see a patient, is telling them that we need more time and advocating for a true amount of time with the patient. And then if you don't have the time in those clinical visits, making sure that someone on the care team does have that time to build rapport. Because
That's great.
healthcare is a journey and a partnership, and so is research. At least it should be, especially the type of work that Robert and I both do. Should we
That's
answer the
great.
question about Alaska?
You can try.
All right. So to our colleague that posted about research in Alaska, there are some programs that actually do telehealth research in Alaska. I'm happy to connect with you offline with some of those programs. There's not a lot of things in the dementia space. A lot of that work is in psychology and psychiatry, and also looking at clinical practice. But many of it is being done via telehealth. And a lot of that work comes out of where I used to work at Mayo Clinic. But I'm happy to connect with you and even put you in touch with a colleague that built a really strong research program in Bethel and in Anchorage.
That's great. That's really helpful. We only have, a couple of minutes left, and I don't know, there are a few other questions maybe that popped in here.
So the question
There is a
from
question
Gay,
about Montana, and Indigenous American populations.
we're trying to get data. Is this a question from Gay?
This was a question from Lynette Perkins. So currently we're facing similar questions and problems in Montana with our Native American populations. Do you have any suggestions? I think it's about figuring out how to have access to people and people to have access to you.
So one of the things with, especially with communities that might be connected to reservations and things like that, making sure that you connect with the physicians and the care teams or the universities that are on the reservations, not just going in from our institutions to those spaces, but then also finding out if they have tribe review boards like IRBs as well, to make sure that what we're doing is not going to cause more harm. Think back to the Habasutai tribe and all of that, and how and those communities that were damaged when research studies findings were coming out. Happy to have another dialogue. The same researcher that I mentioned before, not only does she have research in Alaska, but she also has research in a variety of communities like Utah, Nevada, and Minnesota, with some of those communities in different indigenous communities. So happy to
That's
talk
great.
afterwards and put her in touch with.
Thank you, Joy. And I should mention one of the attendees did remind us, and thank you for doing that, that IA Squared has a CDC and Healthy Brain Initiative grant and they may also be helpful with these questions.
I need to know too, because
So
I
that
gotta
would be
write some more
terrific.
grants.
I think it's just about it is 4 o'clock. I think both Sue and I want to thank both of you for a terrific discussion. I think this was really such important information and very useful. And as I think, as both of you intimated, much more to unpack here, but really does cross the world between not just academia and community, which is where we started, but really crosses the world between research and healthcare. And so I think we have a lot to learn in both spheres from one another and from ourselves, perhaps, in being able to be more impactful in what we seek to do, which is ultimately helping other people, and particularly people who are suffering through or dealing with cognitive difficulties. So thank you both very much.
Thanks to our
Thank you for having
presenters
me.
and to those of us who came to listen. I think we
Yeah,
all
thanks.
learned a lot. Thank
Thanks
you.
very much.
Thank
Bye-bye.
you so much for having us.
Oh, it's a pleasure. We'll have you back.
Bye now.
All right. Bye-bye.